Hello everyone, how are you? I wish you're fine. I wish you enjoyed the first introduction to endocrine therapy. Now we will continue the basics of endocrine therapy for early breast cancer. And now we will focus on the advances beyond the 5 year of endocrine therapy with tamoxifen that we have seen before. These are my disclosures. If you remember from previous video, this is the Oxford meta-analysis showing the value of adding 5 years of adjuvant tamoxifen to lower the risk of recurrence by around 40% and the risk of death by around 30%. But if you notice, even in the presence of those 5 years of tamoxifen, around 1 in every 3 women suffers breast cancer recurrence or metastasis, and in addition, 1 in every 4 dies of her cancer. And the real challenge remains how to solve this problem. So let's remember from the previous lecture the bold step taken by Dr. Cade to remove the adrenal gland surgically in order to treat metastatic breast cancer. For years, we didn't know how was this adrenal gland implicated in breast cancer. As we all know, it does not secrete estrogen. But if we look back to the biology of estrogen synthesis, we find one very crucial step in it, which is the aromatase enzyme. It is responsible to convert androgens to estrogens, and this enzyme is abundant in the ovary in young age. However, after menopause, the body contains very little estrogen. That's not enough to maintain the same estrogen-dependent actions as before, but it can stimulate the growth of ER-positive breast cancers. But where does estrogen come from? Now we know that aromatase enzyme is present in the adrenal glands, body fat, muscles, and bones. And this can convert the very little androgens secreted by the adrenals. This is one reason why the surgery of Dr. Cade worked. This extra ovarian aromatization can be inhibited by the enzyme, by the drug called aromatase inhibitors. And while the surgery to remove the adrenals is really tough and it doesn't always work, having a medication that inhibits the aromatase enzyme can help a lot. And aromatase inhibitors chemically have went through many steps of development, and the third generation of this class finally worked. Now we have 3 effective aromatase inhibitors, that's letrozole and estrozole, which are called non-steroidal aromatase inhibitors, and exemestane, which have a steroid ring, and hence it's called a steroidal aromatase inhibitor. So can we put this into action? The ATAC trial did compare the aromatase inhibitors to the standard of care, which is tamoxifen. It randomized patients with early breast cancer after surgery to one of 3 arms. The first is tamoxifen for 5 years, and that's the control arm. And the second is anastrozole, which is the non-steroidal aromatase inhibitor. And the third arm tried to use the combination of both. Hence, the study was called the ATAC, anastrozole, tamoxifen alone or in combination. Unfortunately, the combination arm did not work. It increased the side effects and it did not increase the effectiveness. And so finally we have the 2 arms, the main arms of single agent to compare. So the results of the ATAC study were very impressive. The disease-free survival, which is the primary endpoint, was significantly improved with anastrozole versus tamoxifen, and the absolute difference was around 3% at 5 years, and with longer follow-up at 10 years, the disease-free survival advantage with anastrozole was 4%. In addition, we observed a very significant observation regarding the side effects of the aromatase inhibitors. Now we know they have a different safety profile compared to tamoxifen. First, we have an increase in the incidence of arthralgia, that's joint pains, and of fractures and bony pains. So this is due to the bone losing effect of anastrozole compared to tamoxifen. On the other hand, patients who used tamoxifen had more risk of vaginal bleeding, vaginal discharge, and endometrial cancer, and this is due to the estrogen-like action of tamoxifen. In addition, Also, due to the estrogen-like action of tamoxifen, we have an increased risk of thromboembolism. And that was observed also with studies that used more than 5 years of tamoxifen. The second study that tested aromatase inhibitor used the second aromatase inhibitor, that's letrozole, and it did have some significant difference in the design. First, there was a two-arm options that was not very important in the current practice, so we discarded, but we compare the four-arm options that randomized patients after successful surgery, like the ATAC study, to one of four arms. The first is tamoxifen, the standard arm. The second is letrozole, and that's similar to the second arm of the ATAC study, but the third and fourth arm are really significant. They used sequential regimen of 2 to 3 years of tamoxifen, followed by 2 to 3 years of letrozole, a total of 5 years, but with different agents, and the fourth arm with 2 to 3 years of letrozole, followed by 2 to 3 years of tamoxifen. And hence it compares, like the ATAC study, tamoxifen to aromatase inhibitor, but it also involves new strategy, which is the sequential strategy. Again, regarding disease-free survival results, very similar improvement was seen with letrozole compared to tamoxifen, 3.5% at 5 years and 4.5% at 3 years. So this confirms the idea that aromatase inhibitors are superior to tamoxifen with around 5%. In addition, we see some very impressive results in the overall survival. So letrozole could decrease the deaths from breast cancer compared to tamoxifen. Here we can see this can reach up to 4% of absolute gain at 8 years. However, in my opinion, the more impressive results of this trial came from the sequential arm. At least after very long follow-up of this study, we can see that the two sequential arms, they have like a similar effect to letrozole. So you can achieve similar gain to 5 years of aromatase inhibitor with a sequential regimen of tamoxifen first, then aromatase inhibitor, or the reverse of aromatase inhibitor first, then tamoxifen. As you can see, the three arms appear to be superior to tamoxifen at 8-year follow-up. So the third study tested a new design, that's the sequential design. In patients who started the adjuvant therapy with tamoxifen, remains an important question: to continue the 5 years, or if you switched early at 2 to 3 years to an aromatase inhibitor. And here our study tested the switching to exemestane, the third steroidal aromatase inhibitor. Whether this switch would improve the outcome or not, the IES study was testing this point. The results were impressive. Again, after 2 to 3 years of adjuvant tamoxifen, switching to exemestane for the remaining 5 years improved disease-free survival compared to continuing tamoxifen. And this confirms that the value of adding aromatase inhibitor is independent of the duration or the strategy. So you could achieve the similar effect if you switch to aromatase inhibitor after 2 to 3 years, or if you replace the total 5 years of tamoxifen with aromatase inhibitors. On the other hand, the team study tested the other way around, to compare sequential tamoxifen followed by exemestane, and that's the winning arm of the IES study, to the 5 years of upfront exemestane that replaced tamoxifen. So this is a very important question. It's similar to the second and third arm of the Big 198 trial. For the results, the team study could not show any difference between the sequential arm with tamoxifen then exemestane compared to the 5 years of exemestane, meaning you can just choose whatever strategy you use, the upfront or the sequential strategy, according to the safety data or the safety profile of your patient. So the final question regarding the use of the aromatase inhibitor in the adjuvant setting is, what if you already finished 5 years of adjuvant tamoxifen? Could you switch to aromatase inhibitor after that? And that's a strategy that's now named as the extended adjuvant strategy, the extension of our adjuvant endocrine therapy beyond the 5 years. So the MA17 was the first trial that introduced this philosophy. It recruited patients who are postmenopausal after primary breast surgery and completed the 5 years of adjuvant tamoxifen, and those patients were randomized to one of two arms, either to go for placebo, that's typically nothing, or to go for an additional 5 years of letrozole. So now the duration is 10 years, and a new agent that isotretinoin is added. Well, the results carried happy news to breast cancer patients where this extension of the duration of endocrine therapy with letrozole resulted in a significant improvement in disease-free survival compared to the placebo arm. And this improvement opened the door for, again, the new era of extended adjuvant therapy, and this study was stopped early due to the significantly positive results after only 2 to 3 years of letrozole, especially in those with node-positive population, a subgroup that most of the oncologists nowadays consider candidate for extended adjuvant endocrine therapy, whatever the first 5 years were. However, this improvement comes with a significant cost in terms of side effects. Because we're increasing the duration of endocrine therapy, now we are seeing more and more hot flushes, more and more arthralgia and bony pains that are typically related to the symptoms of letrozole. So the musculoskeletal symptoms might be a very limiting factor if you consider to use extended adjuvant endocrine therapy in patients who completed 5 years of endocrine therapy. And finally, the Oxford group have conducted their meta-analysis to compare aromatase inhibitor containing adjuvant therapy versus the standard tamoxifen. And here we can see that aromatase inhibitor containing therapy could decrease the risk of recurrence compared to tamoxifen by 3.6% at 10 years. And in addition, aromatase inhibitor could decrease the risk of death from breast cancer at 10 years by around 2%. And finally, while deciding or not to use aromatase inhibitor in the adjuvant setting, we must weigh the pros versus the cons. First, it improves the disease-free survival again by 3 to 5% at 10 years, and it improves the overall survival by around 2% at 10 years. However, it adds extra cost to the adjuvant therapy, and it increases some side effects, particularly the musculoskeletal pains and the osteoporosis and fractures. And when deciding how to use aromatase inhibitor in the adjuvant therapy, you must choose between one of the three strategies. The first is to substitute the total of 5 years with aromatase inhibitor. We call that the upfront strategy. And the second is to use the switch or the sequence method, where you do use 2 to 3 years of tamoxifen and 2 to 3 years of aromatase inhibitor. Or finally, give more than 10 years of adjuvant endocrine therapy, that's 5 years of tamoxifen or 5 years of aromatase inhibitor, or any other combination that involves 7 to 8 years of adjuvant endocrine therapy. The second question is, what if the patient is young? What if she's premenopausal, so the aromatase inhibitor doesn't add a lot? To be able to answer this question, let's go back to where our story began. Do you remember Dr. Beatson from the year 1896, where he treated young patients with metastatic breast cancer with surgical ovariectomy and achieved great success? And he opened the door for the concept of endocrine therapy for breast cancers. Now, in year 2023, is there a chance to treat patients with early breast cancer with castration, in addition to any other endocrine therapy, for example, like tamoxifen? So back to the biology of our cancer cell and every other normal cell in the body, there are two ways to target the estrogen signaling in cancer. First is what we did last time, to block the receptor with the competitive inhibitor like tamoxifen. And the second way is to ablate the estrogen itself. And one way to do that is the old way through surgical castration. However, in the past 120 years since Dr. Beatson, two other ways for ovarian ablation have emerged. First is the radiation therapy to the ovaries, and it's moderately effective as an ovarian ablation and has some side effects which usually does not make it the preferred option nowadays. The second method for ovarian ablation actually depends on how estrogen is secreted. If you remember from last lecture, the estrogen and progesterone secretions are triggered by the mid-cycle LH and FSH. This surge of FSH and LH is in turn triggered by the pulsatile LHRH secreted from the hypothalamus. If you give an LHRH antagonist, then this will stop the ovulation and minimize the estrogen senses. The tricky thing is that even if you give an LHRH agonist for a steady non-pulsatile levels, which can be achieved by a long-acting depot injection, for example, you can inhibit the estrogen senses by silencing the pulsatile secretion that should come from the pituitary. This inhibits both ovulation and the secretion of sex hormones. So the question is, why not add ovarian function suppression to tamoxifen following surgery in premenopausal women? It could help in patients with metastatic disease, and it improved the survival when added to tamoxifen. The question is, could this combination with tamoxifen or even with aromatase inhibitor help in the adjuvant setting? And here comes two very important clinical trials. The SOFT study, which is a randomized trial that was designed to test this question. It recruited around 3,000 patients with early breast cancer after successful surgery and randomized them to one of the three logic options of endocrine therapy you could think of. It's interesting how nobody conducted similar study since ages. It randomized patients to one of the three arms. The first are tamoxifen alone, the second is tamoxifen plus ovarian function suppression, and the third is ovarian function suppression plus exemestane, the aromatase inhibitor. Another very relevant study is the TEXT trial, which tested similar patients but for the last two treatment options only, ovarian function suppression plus either tamoxifen or exemestane. So when we compare tamoxifen versus aromatase inhibitors in patients who are receiving ovarian function suppression, then we combine the second and the third arm of the SOFT study with the two arms of the TEXT study. So what happened in the results of the SOFT study? A very interesting observation is even after the first 5 years of follow-up only, in this indolent disease, we can see the difference. In the whole population, exemestane plus ovarian function suppression seemed to be the winning arm with a 5-year disease-free survival rate of around 91%, followed by ovarian function suppression plus tamoxifen with around 88%, and finally tamoxifen alone being the loser arm with a disease-free survival at 5 years of around 86%. Of course, we should look into the patient subgroups who have gained the most benefit from this treatment escalation. The patients were stratified by whether or not they received chemo. And on the left-hand side, we can see those patients who were low risk in the oncologist's opinion to receive chemotherapy. Most were older than 40 years old, node negative, and with lower grade T1 tumors. Those patients had very good prognosis even if they received tamoxifen alone. On the other hand, most of the disease-free survival improvement with the addition of ovarian function suppression and exemestane was much more pronounced in patients who had received prior chemotherapy, with around 7.7% improvement with ovarian function suppression plus aromatase inhibitor and 4.5% improvement with ovarian function suppression plus tamoxifen over tamoxifen alone. So the last important lesson from the 5-year follow-up result is this. In patients less than 35 years and maybe also less than 40 years, Tamoxifen alone is not enough. We must add ovarian function suppression at least. The difference in such young patients may reach up to 20%. Again, with longer follow-up, we started to see the benefit of adding ovarian function suppression, and adding exemestane gets wider and wider. These are the 8-year results in all comers with absolute gain reaching up to 7%. And in the high-risk population who received chemo, getting a difference up to 9% compared to tamoxifen alone. With more and more longer follow-up, here at the median of 13 years, we can see even the difference between the two arms with ovarian function suppression. Exemestane does significantly better than tamoxifen, with a 5% gain at 12 years regarding disease-free survival in the whole cohort. In addition, a significant 2% difference starts to appear between the two arms in overall survival. Of course, the difference is higher as the patient risk goes up, and of course, the difference might increase with more and more time of follow-up. Finally, if you decide to use ovarian function suppression plus either tamoxifen or exemestane in a premenopausal woman, you must pay good attention to the side effects. This treatment is not easy to tolerate. First, you can see at this table that around 50% of patients suffer some sort of depression, and around up to 5% of them have a high-grade depression which might reach suicidal attempt. In addition, sexual dysfunction symptoms, vaginal dryness, decreased libido, dyspareunia, and some urinary symptoms are also increased significantly, which will impair the quality of life so much. And that's a reason of why in the SOFT trial, for example, a non-adherence to ovarian function suppression was observed in up to 20% of patients after 4 years of follow-up from randomization in the study. And this is a very high rate of treatment discontinuation or non-compliance for endocrine therapy. To compare to the Oxford meta-analysis did not find that patients who received 5 years of adjuvant tamoxifen had any increase in uterine cancer or pulmonary embolism, for example. So this must guide you when deciding on the adjuvant therapy. In low-risk patients, you might want to skip them from the suffering of a toxic and a harsh treatment like ovarian function suppression, while in those with high-risk patients, you might need to counsel them about escalating the treatment to ovarian function suppression plus tamoxifen or exemestane. So my final conclusions regarding this attempt of treatment escalation beyond 5 years of tamoxifen, that patients with ER-positive breast cancer need adjuvant endocrine therapy, at least 5 years of tamoxifen. There are some very low and low-risk patients who can safely depend on the 5 years of tamoxifen alone. However, in most patients with intermediate risk and high risk of recurrence, adding aromatase inhibitor is essential in postmenopausal patients using one of the 3 strategies we discussed, and adding ovarian function suppression plus either tamoxifen or plus aromatase inhibitor is needed in patients with premenopausal breast cancer who finished adjuvant chemotherapy. And thank you very much for your attention. For more videos about breast cancer and about clinical research, please subscribe to the channel below.